morning, everyone. Thank you so much for joining our call today. So I'm going to provide an overview of monkeypox, discuss how healthcare providers can collaborate with public health to control this outbreak, and show you some tools that VDH has developed. Next slide, please. One more. So monkeypox is a viral zoonotic disease that historically occurred primarily in rainforest areas of countries in Central and West Africa. Unfortunately, it is now causing a multi-country outbreak. As of yesterday, over 1,300 confirmed or suspected monkeypox cases have been reported in 31 countries where monkeypox is not currently endemic. Just over half were in the UK, Spain, and Portugal. Thankfully, few hospitalizations and no deaths have been reported. Most, but not all of these cases have been reported among men who have sex with men, and the majority of cases have no established travel links to a country where monkeypox is endemic. Many of these patients have presented through primary care or sexual health services. Next slide, please. Additionally, the World Health Organization continues to receive reports on ongoing outbreaks occurring in countries where monkeypox is endemic. The Democratic Republic of Congo has reported over 1,200 cases since January. Nigeria has experienced a large outbreak since 2017 with over 700 suspected or confirmed cases and a case fatality rate of 3%. They've reported 87 cases since January, including 1 death. Next slide, please. As of yesterday, 40 cases have been reported in the United States, including 1 in Virginia. The first US case was reported on May 18th in a Massachusetts resident who had traveled to Canada. Next slide, please. On May 27th, a case was confirmed in an adult female resident of Northern Virginia. She had recently traveled to a West African country and has had mild illness not requiring hospitalizations. So CDC has identified 2 distinct monkeypox virus lineages that are occurring among current cases. One is the outbreak strain, which is closely related to sequences from the current outbreak in Europe, but Virginia's sequence is genetically distinct from that, and it's related to a common ancestor of other cases with travel to an endemic country. The local health department has identified and is monitoring the Virginia cases close contacts, and 3 people are receiving post-exposure prophylaxis. Additionally, we're monitoring 9 intermediate risk contacts of other US cases, which were reported from flight exposures, and we're assessing 1 high-risk contact to DC's recent case. Our clinicians across the state continue to report additional suspected cases, and the local health departments are working with them to assess risk and coordinate testing where indicated. Next slide, please. On May 29th, the World Health Organization assessed the general risk to the public as low. However, they assessed the overall public health risk at the global level as moderate. This is the first time cases and clusters have been reported concurrently in wide, disparate geographic areas and without known epidemiological links to endemic countries. The sudden appearance of cases simultaneously in several non-endemic countries suggests undetected transmission for some time, as well as recent amplifying events. They determined that immediate action is needed to avert the establishment of monkeypox as a clinical condition in currently non-endemic countries. So this situation is rapidly evolving, and it's critical that healthcare providers stay alert for patients with signs and symptoms of monkeypox so we can identify cases early. Next slide, please. The monkeypox virus is in the orthopox virus genus, which also includes variola virus, that's the virus that causes smallpox, and vaccinia virus, which is used in smallpox vaccines. There are 2 clades of monkeypox virus. A clade is similar to a strain. A strain's not the technical word, but a word you're probably familiar with. So the 2 clades of monkeypox virus, the first is the Central Africa or Congo Basin clade, and that has historically caused more severe illness with a case fatality rate of up to 10%. Currently, the DRC is reporting a case fatality rate of 3% among suspected cases. The West Africa clade is the virus that has been identified in the current outbreak in non-endemic countries. Several European countries and the US have already published the genome sequences of the outbreak virus. The West Africa clade has caused less severe disease than the Central Africa clade and has historically had a case fatality rate of about 1%. Since 2017, deaths from the West Africa clade have been associated with young age or untreated HIV infection. Next slide, please. So uncertainty remains about the natural history of monkeypox virus. The wildlife reservoir is unknown, but African rodents and non-human primates are thought to be involved in how the virus is maintained in nature. Historically, monkeypox disease in humans has been rare. The first case was identified in DRC in 1970. Before this outbreak, cases were rarely exported to other countries. The first outbreak outside of an endemic country occurred in the United States in 2003. You may remember this. Imported African rodents infected prairie dogs in the US, and 47 people in 6 states developed illness due to exposure to prairie dogs. We didn't have a case in Virginia. Next slide, please. So transmission from infected animals to humans is believed to occur primarily through direct contact with lesions and respiratory secretions. Human-to-human transmission occurs through close contact with lesions, body fluids, large respiratory droplets, and contaminated materials. Limited data on monkeypox transmission are available, though, and different monkeypox strains may have different epidemiological properties, including human-to-human transmission. However, in the past, transmission in healthcare settings has been rarely described. 4 instances of monkeypox transmission within hospitals have been reported in Africa among children, usually related to sharing the same bed or ward. Additional recent literature documents transmission of Congo Basin monkeypox in a hospital compound, and there's also a report of transmission in the UK. The incubation period on average is 6 to 13 days with a range of 5 to 21 days. A person is infectious from the onset of symptoms until all lesions have crusted, the crusts have separated, and a fresh layer of healthy skin has formed underneath. Next slide, please. In this multi-country outbreak to date, the clinical presentation of confirmed cases has been variable. Many cases are not presenting with the classical clinical picture of monkeypox. The classic signs and symptoms of monkeypox are similar to smallpox, but are much milder. They begin with a prodrome, which can include fever, headache, muscle aches, backache, lymphadenopathy, chills, or exhaustion. And a differentiating sign between smallpox and monkeypox has been lymphadenopathy. Within 1 to 3 days, patients develop a rash, often including both oral mucosal and cutaneous lesions. And then the cutaneous lesions often begin on the face and then spread to other parts of the body. Skin lesions progress through sequential stages of macules, papules, vesicles, pustules, and then they scab. The lesions are relatively the same size and at the same stage of development on a single side of the body in classical monkeypox presentation. The illness is generally self-limited and lasts 2 to 4 weeks. But in cases described thus far in this outbreak, common presenting signs and symptoms include genital and perianal lesions, fever, lymphadenopathy, and pain when swallowing. Oral lesions remain a common feature. The World Health Organization has noted that a local anogenital distribution of rash with vesicular, pustular, or ulcerated lesions sometimes appear without consistently spreading to other parts of the body. Some cases have been described as having pustules appear before constitutional symptoms. And additionally, asynchronous progression of the rash has been noted, with lesions on the same part of the body at different stages of development. The differential diagnosis may include secondary syphilis, chancroid, herpes, chickenpox, and varicella zoster. Next slide, please. So monkeypox lesions are characteristically well circumscribed, deep-seated, and often develop umbilication. Lesions are often described as painful until the healing phase when they become itchy. Next slide, please. It's important to take a thorough patient history that includes asking about travel in the past 3 weeks. Patients should also be asked about close contact, including sexual contact with someone with a rash, contact with a dead or live wild animal from or while traveling to an endemic country, or using a product derived from such animals like game meat, creams, lotions, powders, etc., and also about contact with an exotic pet, particularly rodents and non-human primates. Next slide, please. Testing specimens of patients suspected to have monkeypox at DCLS, Virginia's State Public Health Lab, needs to be coordinated with your local health department. You will need to use 2 to 4 paired dry swabs, not viral or universal transport medium, to collect material from lesions or different body areas. 1 to 2 swabs will be tested at DCLS, and 1 to 2 swabs will be forwarded to CDC if positive at DCLS. Samples should be refrigerated within an hour of collection and can be stored up to 7 days at 4 degrees centigrade. Transport specimens on ice and use a routine DCLS courier. Next slide, please. So DCLS performs real-time PCR for both non-variola orthopox and orthopox virus, and that is used for the presumptive identification of monkeypox virus. At this time, DCLS test results are provided within a day from the start of the test. A positive test at DCLS is a presumed case, and it's treated as such for public health purposes. Specimens will be sent to CDC for confirmatory testing of monkeypox, and currently CDC's turnaround time is 5 to 7 days for formal reporting of results. Next slide, please. So there are no specific treatments for monkeypox approved in the United States, but TPOXX, cidofovir, and vaccinia immune globulin are treatment options that may prove to be beneficial, and they can be accessed through the federal government under an expanded access investigational new drug protocol. Next slide, please. Cidofovir is currently available, but CDC is developing an expanded, is currently not available, apologize, but CDC is developing an expanded access IND to prepare for potential use in the future. Next slide, please. So as always, ensuring good infection control practices is critical. Patients should be isolated in a single room with a dedicated bathroom. The door should be kept closed if it's safe to do so. When patients are transported outside of their rooms, they should wear a medical mask and have any exposed skin lesions covered with a sheet or gown. You should use standard and transmission-based precautions. CDC recommends that personal protective equipment include a gown, gloves, N95 respirator, and eye protection. Procedures should be performed, procedures that are likely to spread oral secretion should be performed in the airborne infection isolation room. Also, we recommend avoiding activities that might spread and resuspend dry material from lesions. Next slide, please. So you can perform routine, whoops, you can go back one. You can perform routine environmental cleaning and disinfection. And there's instructions on the CDC website, and there's a link on this slide, which we'll share with you. For cleaning, use an EPA-approved product labeled with emerging viral pathogen claims. We recommend using wet cleaning methods. And for waste, you can sequester the waste that's associated with managing the patient while confirmatory testing is pending. So the Congo clade is actually considered, waste associated with the Congo clade is managed as category A, but the West Africa clade does not have to be managed as category A. But unfortunately, that does require sequencing to understand the difference. So you can sequester the waste, and then if it is consistent with the West Africa clade, that can be managed differently. If not, waste has to be managed as category A. Next slide, please. So as always, we hope you'll be working closely with your local health department. Next slide, please. I think you all know now, after all of the experience with COVID-19, how to work closely with your local health department. But we do have on our website a locator, so you can identify a local health department if you have any questions. Next slide, please. So public health actions that can help control the outbreak, which we'll be using, include intensifying surveillance for monkeypox cases, identifying cases early, conducting laboratory investigation, including genomic sequencing, implementing infection control measures, isolating cases, conducting contact tracing and monitoring contacts, providing guidance and education, and conducting outreach to social networks of MSM and their contacts. Next slide, please. CDC has established case definitions for epidemiological surveillance, and I've included them on this slide for reference. Next slide, please. The current epidemiological criteria for case identification include patients who within 21 days of illness onset report having had contact with someone who has a similar appearing rash or was diagnosed with monkeypox, or had close or intimate contact with an individual in a social network experiencing monkeypox activity. That includes men who have sex with men, or traveled outside the US to a country with confirmed cases of monkeypox, or where monkeypox virus is endemic, or had contact with a dead or live wild animal, an exotic pet that is an African endemic species, or a product derived from such animals. Next slide, please. A case may be excluded if there is an alternative diagnosis that can fully explain the illness, or an individual with symptoms that was consistent with monkeypox does not develop a rash within 5 days of illness, or a case where high quality specimens do not demonstrate the presence of orthopox virus, monkeypox virus, or antibodies to orthopox virus. Next slide, please. There are 2 vaccines available for contacts who meet exposure criteria for post-exposure prophylaxis. They are Jynneos and ACAM2000. CDC recommends that vaccine be given within 4 days from the date of exposure to high-risk contacts and be considered for intermediate contacts in order to prevent onset of the disease. If given between 4 to 14 days after the date of exposure, vaccination may reduce symptoms of disease, but may not prevent the disease. The risk level of the contacts is evaluated based on the exposure and the circumstances around that, and the local health department will help determine that. Next slide, please. So Jynneos was licensed in 2019 in the United States to prevent both smallpox and monkeypox. It's a replication deficient live vaccinia virus vaccine, and it's administered by subcutaneous injection as a 2-dose series. CDC recommends it for people 18 and older who are at high risk for monkeypox due to occupational exposure, or they've been exposed to a monkeypox virus. Next slide, please. ACAM2000 is a live vaccinia virus vaccine that was approved in 2007 for active immunization against smallpox for persons determined to be at high risk for infection. It's administered under an IND, and it's administered percutaneously using 15 jabs of a bifurcated needle. It causes a skin lesion, and that has infection control risk because you can have auto inoculation or infect others. Next slide, please. So Jynneos is a newer vaccine than ACAM2000. The effectiveness data, other than from clinical trials, are not yet available, but the clinical trials did not indicate specific safety risks. ACAM 2000 has been shown to be effective, but it is more difficult to use because of the skin lesions that are caused by the vaccination process. It also has a number of contraindications, some of which apply to conditions of household contacts. Next slide, please. Local health department staff will work with you to request medications and vaccines as part of the case investigation process. At this time, all requests must be made by VDH in consultation with CDC. So at this time, according to CDC, the US does have enough vaccine to respond to the current monkeypox outbreak. Next slide, please. We have developed some tools that may be useful to you. Next slide, please. The first is a preparedness checklist for healthcare facilities. I recommend that you review this and see what is relevant to your practice. Next slide, please. There's also a healthcare assessment tool that can be used to guide exposure assessment and the need for post-exposure prophylaxis and to monitor contacts. Transmission of monkeypox does require close interaction with a symptomatic individual. Additionally, we have some fact sheets and other information on our website. You can see the link at the bottom of this slide. So when for looking at the exposure risk, a high exposure risk requires active monitoring of signs and symptoms, including temperature checks at least twice a day for 21 days post-exposure, and offering post-exposure prophylaxis, as I said, ideally within 4 days, but up to 14 days. Intermediate risk requires active monitoring, but determining whether post-exposure vaccine will be given is made on a case-by-case basis. Low or uncertain risk requires self-monitoring of symptoms, which includes a temperature check at least twice daily for 21 days. But post-exposure vaccine is not recommended. Healthcare facilities will monitor their own staff members and consult with the local health department for unusual exposure situations. Exposed healthcare personnel do not need to be excluded from work if they remain asymptomatic. Next slide, please. So our take-home messages for you are that the risk to the general public at this time is low, but now is the time to ensure your healthcare facility and practice is prepared. And when evaluating patients, have a low index of suspicion for monkeypox if characteristic rash or other epidemiological factors are present. Consult and collaborate with your local health district and stay up to date on the latest information and recommendations regarding monkeypox, both through the CDC and the VDH websites. Next slide, please. This is links to good resources on both the VDH and CDC and other websites. So you'll have these slides and can reference them. And I think that's it. I'll turn it back to you for questions. I think you might be on mute.
Hi, Dr. Peak. This is Dr. Nanda. Thank you for a wonderful presentation. I apologize for joining everyone a little bit late. And as with all MSV webinars, this will be posted to the MSV website at www.msv.org. Questions for Dr. Peak can be asked in the chat, or you can raise your hand. And I thought that was a really informative and complete presentation. So fantastic. And thank you for doing it. Are there any questions for Dr. Peak? The marketing team has put in the chat the webinar link. And let me see if any. I'm looking at the gallery view. I don't see it. Are there any questions? Okay. Well, I'm not seeing any questions. So thank you so much. Thanks for presenting, and I appreciate it very much.
Great. Take care.
Okay.
Bye.
Thanks everyone for joining.